So what is this rosacea? So this is also called as the acne rosacea, but remember students, this is not related to the acne vulgaris, which you need to remember. So both are different diseases. There are certain similarities. Both of them are chronic inflammatory disorders of the pilosebaceous unit, that is the sebaceous gland and the hair follicle. Okay, but in acne vulgaris the involvement of face will be there and also trunk will be there, whereas in rosacea the lesions or the skin changes are only going to be limited or confined to face. So what are the causal associations in rosacea? So in acne vulgaris, I hope all of you know the bacterium Propionibacterium acnes is associated. Here it is a mite in rosacea which is Demodex folliculorum. What is the other mite which you can remember in dermatology postings in the OPD which you might have seen? The disease name is scabies, and if you have thought of the mite as Sarcoptes scabivar hominis, you are absolutely correct. So what are the exacerbating factors in the rosacea? Remember students, there are so many triggers, like for example topical steroid usage can trigger the rosacea. So there are certain dietary food items or beverages which can trigger, like for example hot tea, coffee, okay, spicy foods, garam masala, coffee, caffeine, okay, alcohol. So these are all the triggers. Environmental triggers, you can remember the sun exposure, okay, and also hot climate. So basically hot food or hot environment is going to trigger the rosacea. Lifestyle and psychological factors which can produce stress, exercise, and emotions. And also remember, it is rosacea is commonly seen in the woman, and ovulation, menstruation, menopause, these can also act as a trigger. Okay, so now coming to the clinical features of the rosacea. So particularly this is going to mainly affect the females, and that too those who are with having a lighter skin and the eyes. And in the skin manifestations, remember the patients are going to have papules and pustules which are looking like acne lesions. But what is the important difference in the lesions of acne vulgaris and acne rosacea? Yes, in acne vulgaris, the patients are going to have the lesions which are pathognomonic, which are called as comedones, whereas comedones, that is the blackheads or whiteheads, they are absent in rosacea. Okay, so now coming to rosacea, the patients are going to present with erythema over the cheeks, and this is called as flushing. Okay, this is called as flushing, or we can say persistent erythema. And the patients can also have telangiectasias, that is dilated blood vessels over the cheeks, nose, and the chin. But remember, this rosacea is mainly a disease of the face, and that too mainly of the central portion of the face. So here you are able to see that the patient is having over the nose the dilated blood vessels. These are called as a telangiectasias, and also you are able to see the cheeks, the malar area is having the redness due to the dilated blood vessels. And the patients can also have the papulopustular type of lesions which are looking like acne lesions. So they are called as acneiform papules and pustules. So this is from the Harrison book. You can see the acne rosacea. The lesions are predominantly going to be seen over the central part of the face. So what are the associations? What are the important terms which you need to remember related to the rosacea? Rhinophyma. So phyma is just a term, broad term, which will help you to understand. Remember that skin is going to become thickened and the skin will show irregular surface changes. So if the irregular surface is present over the nose, we call it as rhinophyma. Basically here there is going to be hypertrophy and hyperplasia of the sebaceous glands. Okay, and there can be ocular involvement seen in these patients also, and there can be conjunctivitis, inflammation of the conjunctiva, there can be eyelid inflammation, keratitis, iritis. So any kind of inflammation can occur in the eyes. So that is the ocular involvement of rosacea, important for you to remember. So here you can see this is a picture which is showing the rhinophyma. This is rhinophyma where you are able to see the irregular surface of the skin over the nose. So this video, I hope it was helpful, valuable. So if it is helpful, valuable, please do hit that like button. Do not leave this video without hitting that like button. Okay, we shall continue the topic. So diagnosis is mainly clinical. There is no requirement of any investigation. And the management is going to, we should tell the patient so to avoid all the triggering factors. Okay, so they have to use a sunscreen because it will protect from the sun rays, and to avoid any triggers, so alcohol, spicy food, hot beverages, okay, whatever it is, and extreme of the temperature, and they should stay in the cool. And first line of treatment, mild disease if it is there, and we are going to use topical metronidazole, clindamycin, and also ivermectin because it is a mild possibility is there, so this can also be used, and azelaic acid. So these are the topical agents which can be used. And if there is persistent erythema and telangiectasia because of the dilated blood vessels, we can give some agent which can produce vasoconstriction, like for example the brimonidine can be used. So if the patient is having moderate to severe disease, oral antibiotics can also be used. The antibiotics are mainly used not for their antibacterial mechanism of action, but because of the anti-inflammatory properties, like for example doxycycline, minocycline, and metronidazole. Okay, so these are the antibiotics which are used. And if there is a telangiectasia which is not responding to the topical agents, then we can also think of the laser therapy. We can think of laser therapy. So, what are the contraindications? Avoid the topical steroids, glucocorticoids, because they are the trigger of rosacea. Okay, and ocular rosacea. See, the topical agents which we have discussed in the previous slides, they can be used in the skin disease of rosacea, but they do not have any role. They are ineffective in the ocular rosacea. Okay, so what we can do is refer the patient to ophthalmologist for further management. Okay.